Welcome to today's webinar resident series, Implementing Locator Overdentures into Your Practice, Part 2. It is being conducted by Jeff Carlson, CDT, and we will begin shortly. And with that, it is my pleasure to introduce the Adam Dreyfus, Director of University, Government, and Institutions.
I know that everybody is eager to learn from Jeff, but thank you for taking the time this morning to learn with us and join us. But with that, Jeff, take it away.
Hey, thanks, Jessica. Thanks, Adam. Thank you all truly for joining us. Appreciate it. Let's just get right into this. But this is part two. If you recall from part one, it was a lot about diagnostic, patient selection, planning the case out properly, everything from, getting vertical established to implant positions, thinking about where they are today with maybe a two implant overdenture to where would they patient if they wanted to go to something a little more stable or even go to a fixed prosthesis. How would you add more implants? So it's a lot about planning, thinking ahead. Today, it's strictly we're right in there, we're right in the chair with the patient, and what we're going to cover is we're going to take an existing denture the patient has, and maybe they're happy with the denture, they're not happy with the fit. And this happens a lot with the lower dentures. Not many denture patients, as I'm sure you already know this, they're not happy with their lower. The uppers usually can get along with quite often. The upper is usually the biggest issue with the upper is getting rid of that palate because they lose a lot of sense of taste, hot and cold, things like that. But the lower is it's just so hard to function when they lose bone. They lose any opportunity really for some surface area for stability. The tongue, the lingual glands, everything is moving. It's a dynamic movement. It shocks me that some dentures that they're even able to function with them. So we're going to look at how you take an existing denture and we're going to have, so whether it's you or your specialist that you refer to, place two implants and convert that existing denture. So unfortunately for our lab friends, we actually can bypass the lab and just do this all right there in your office. And this really helps you to help those patients who the economics of something is really challenging for them. And it's a wonderful service still to provide your patients. And then we're looking at if you're going to do a new overdenture case, some impression techniques. We're going to cover some of the new things that Zest has. Now, Zest is the manufacturer of the Locator abutment system, as well as other things. They have a digital workflow that's really cool. I think you're all going to like that. And then I am going to time allow. I'm going to try to just take a few slides and introduce you to the fixed version or the Locator fixed, where you could take it to the next level and you have a patient with a two implant overdenture, or maybe it's a four implant overdenture, but you change out the inserts. If it's a two implant overdenture, you do need to add two more implants. So when we get to that fixed, I'll talk to you about that. But how can you take a four implant overdenture case and turn it into a fixed? Again, right there in your practice. Very cool information, and let's get right to it. So hit the right buttons, Jeff. I don't have to do my disclosure because we're not providing CE on this presentation today. It is very commercial orientated because we're talking about specific techniques, specific products. So the Locator abutment, the key for you to remember with the Locator abutment, and even if you're using some clone abutments, this is pretty much a general rule with the clone abutments as well. It's if you look at the diagram here, the gold portion is what they call the cuff height, the gingival height or cuff height. From the top of the abutment down 1.5 millimeters is where the housing with the insert will fit over that. So when you're measuring, looking for a gingival cuff height to determine how tall of a cuff height do you need to protrude through or emerge through the tissue, it's going to be, they're available from about 2 millimeter cuff heights upwards to 7, 8 millimeter cuff heights. So I want to talk to you about helping to select that as well. So what is a problem when you don't select the correct cuff height? You see this one right here. The tissues sometimes have a tendency to hyperplasty up onto the abutment somewhat. And that becomes an issue for the patient from a hygiene perspective. If it gets too close to the abutment, too close to the top of the abutment where the attachment fits to it, and you only have two implants where you have more mobility, which you need that to distribute the loads because these abutments and these attachments are not designed to withstand these vertical loads and cross arch loads that a patient generates during dynamic movement during function. They're designed to retain the denture into place so it doesn't get propelled out of the mouth during speech, during laughter, and during function. So when we can't take a full arch of dentition and only have two implants to support that from a rigid perspective, we need to have this movement to allow the distribution of that load onto the edentulous ridge. And that's something important to explain to patients too, not in the terminology that I just used, because they're not going to understand a word you said, but they need to understand that, and you do it in some words that they helps them to really, in their mind's eye, see that picture that you can't have all those loads on just two implants. It's a cantilever. It'll just torque your implants loose, that we need to have that little bit of movement so that the gums and your under supporting bone takes that load during function. Otherwise, without that movement, these implants would be possibly would come out. So we have in the locator abutment options, you have as far as the attachment options, the insert options, you have what's called the standard inserts on the left, which will compensate for upwards to 20 degrees of divergence from one another. So each abutment could possibly be 10 degrees off of being perfectly perpendicular, which is not uncommon. It is, quite honestly, it's still hard. They look pretty straight up and down in the mouth, but it's still hard to do it, make it perfect. So there's some forgiveness there. If you get a case that the implants are more than that, they do have the ability to go to what they call an extended range, and that kind of doubles the ability to provide a path of insertion without compromising the function of the attachment or extent or causing more wear onto the attachment. So you've got those two options. And then this is something that is newer to the market, and I think this is a wonderful adjunct. So they make they call a locator 15-degree angled multi-unit abutment. Okay, mouthful there. But so if this was bone level, and when a clinician places an implant, typically you're going to see this in the posterior. So this could be the maxillary arch where they're trying to put that implant in front of the sinus. So they're going to angle that implant so that they don't have to do a sinus augmentation. Or it could be where they're trying to stay in front of the mental foramen so that they still want to angle it so that they can get a larger anterior posterior spread. But the point is, when they do that, you're going to see that the implant is going to be typically part of the implant toward the posterior. The direction of the angulation will be subcrestal. So they're going to usually keep the highest point of the implant at bone height. So we have an issue here with the path of insertion because this is going off at an angle. And so that's direct into that. Well, we need to correct that by 15 degrees for this particular case. So they make this one piece abutment, and here you see it on the bottom right, where you can see now when I put the abutment straight, like if it was in a straight implant, now you notice that angulation. But look at the larger photo and you see how it looks straight or flat on the top of that the gold abutment. That's because it's angled in the neck of it, if you will, or the collar of it, that 15 degrees. So if you're off, it doesn't have to be, well, what if it's 20 degrees? What do we do? What if it's 23 degrees? So remember, those attachments have up to 10 degrees forgiveness on each way, or 20 degrees. So you added another 15 degrees here. It's giving you a lot of flexibility to correct angulation. However, still, your clinicians that you're working with, if you need to, from a prosthetic perspective, let them know what some limitations may be if you're planning for a locator abutment, that they need to know some of these limitations. Now, we get into cases that, let's say they went with a 30 degree, or you have a patient that came in that had some implants that were significantly angled, say that 30-degree angle. And this is a standard multi-unit abutment here on the bottom. And MUA stands for multi-unit abutment. Very generic terminology. The acronym's used worldwide. Um, but this abutment could be from just about any implant manufacturer. But what Zest has now is they have a locator collar and then they have a special locator abutment. The gold portion functions the same as everything I'm going to pretty much show you. What's going to be different is just how it connects into the abutment. So what's wonderful about this is it gives you the ability now to correct 30 degrees. Now you do have to use a standard multi-unit abutment, but now you have 30 degrees, and then you can still come up here on the top with those inserts and have that 10 degrees on each side, so that's 20, or the extended range, which was 20 on each side, so that's 40. So you can see there's solutions to when you have angled implants, but what you need to be aware of is that it can cause a little more challenge for you as the restorative clinician and more cost because when you start getting these ancillary abutments components to correct angulation, it does add more cost to the case. But the good news is clinically you can pull out of it, if you will, and still give the patient a wonderful prosthesis or another great option. Uh, we're not going to spend a lot of time on this core tool. This is a tool that you have to have when you're doing a locator. Uh, we're not going to be showing this throughout. I do want to say, my friends, that if you go to YouTube and you just type in locator abutment, the director of clinical research for Zest Anchor implant company, attachment company, Dr. Michael Shear, a prosthodontist, he has, I think it's probably safe to say, over 100 videos, all focused around locator, different scenarios, great videos that he shoots. There's a lot of information for you to there. So just go to YouTube and type in locator abutment, and you'll find a plethora of information for you there. A lot of videos showing how these tools work. And it's important that you know all this. Of course, don't do it when the patient gets there. Now you're trying to look things up. I want to help you a little bit with determining the proper cuff height. And the best way to do this is with the metal probe. And what you're going to do, if the clinician sends it to you with a healing abutment, based on if it's a contoured healing abutment or a straight abutment, healing abutment, a straight abutment, you might be able to do this with leaving it on. But what you're looking to do, this is a metal probe, is you want to take the probe down and you will find the ledge, the table of the top of the implant. And you want to find the highest point of that position. And that highest point would then represent the minimum cuff height, and you want to go 1 to 2 millimeters above that. So I'm going to show you in this next scenario here. So here is an implant, the same height, but we need different height of the abutment. So this is a 2 millimeter cuff abutment, and now you're looking at a 3 millimeter cuff abutment. So what changes is right here in the cuff area to get you through that tissue. So if that tissue height, as you see here below, let's say the highest point of tissue was 2 millimeters. You do not want a 2 millimeter cuff height. You want to go at least 1 millimeter above the measured gingiva height. So 1 to 2 millimeters above that. So this could be a 3 millimeter or 4 millimeter cuff height. The other thing you need to watch out for is that as you go with a cuff height, a taller cuff height, obviously that means that it's going to start using up some of your interarch space, your prosthetic space. And your prosthetic space is the area, their space from the platform of the implant to the occlusal plane. And with these locator abutment systems, you need somewhere around 9 to 11 millimeters. So a lot of these patients that you're working with may have what we call a closed or collapsed vertical, and you need to open their vertical to be able to restore them utilizing whether it's a locator or maybe you want to do an all-on X case. And so based on what the prosthesis is going to be, you may need up towards to 15 to 16 millimeters of that restorative space. So be very conscious about restorative space because that's going to be a real key. Again, a lot of patients, they have that collapsed and they need to be opened a little bit. And so the key that we found is that when you find the patient's rest position, what's called their physiological rest position, which is that relaxed position. Many of you, if you're not having your hand on your under your chin like this, if you're just sitting upright watching this, your teeth are not together. So if you do this right now, go ahead and put your teeth together and then relax again, put your teeth together. You're going from physiological rest position to what we call your functional vertical dimension of occlusion, more commonly referred to as your VDO. So with natural dentition, you have it. There it is. When you're in with an edentulous patient or edentulous arch, you need to establish that VDO, that vertical dimension of occlusion. So we find that the difference between rest and that closed position, the freeway space it's referred to, is commonly 3 millimeters. So hopefully that might help you a little bit when you're needing to kind of zero in on things. And I have some more videos too. My email is going to come up here in the last slide. Please do a screenshot of that. You're welcome to screenshot any of this. As Jessica mentioned in the beginning, that this will be available for you to watch future forward as well. But if you send me an email, I have more things I can send you, a PDF that has links, hyperlinks to some other webinars I've done. Here's a tip for you. Whether you're doing an overdenture or a crown and bridge case, but if you have multiple healing abutments from the case patient shows up, then the surgeons put in, if they have multiple healing abutments, very likely you have multiple heights and diameters. So you don't get them mixed up. When they come out of the mouth, just take a piece of rope wax and shape it into an arch form like you see here, and then place those onto that rope wax. That way, if someone bumps the tray, they don't roll all around the tray, and you know exactly kind of where each one goes. So just a little tip for you. All right, so we have a patient now that has an existing denture, and their major complaint is that they want their denture more stable, keep it from being propelled out of their mouth. More stable was a term I used. I didn't say fixed, locked into their mouth, because you're not going to get that with this locator, 2 implant locator case. There is going to be movement that they're going to be aware of, but it will keep the denture in position during dynamic function, and that's really what you need to make sure that's going to meet their expectation. Because if they want more than that, you need to continue your dialogue, because you can do it, but know that's also going to cost more money, more time, possibly maybe involved in that. All right, so we're going to stick with our mindset here of an existing denture, 2 implants. Let's convert it to a locator. Patients in the chair. Let's get this done in about 45 minutes or so. Not our presentation, but the actual procedure. So the first thing, I'm showing some ball abutments here because it's the same concept. You may inherit a case that's been done, 20 years ago, where they had maybe these ball abutments. These still, you can order these and it can be replaced. Sometimes it's a little challenging if you don't know what implant system it was. But what you're going to first do, whether it's a locator abutment or like you see here, these ball abutments are referred to as O-ring abutments. You put some marker on it. This is a little the ink pencil, and you just mark that and set the denture on, and you'll get your little tattoo mark here where it was. You also can take a little blue mousse and just shoot a little blue mousse or fast set bite registration material, put the denture in, have the patient close down. No adhesive, don't use any tray adhesive. And when that comes out, then you have an indent where the abutment is hitting, and that's your target area that you need to go into and to relieve that. So then you're going to relieve that area, and you're also going to want to put a light coat of Vaseline around that area for when you get some flash. You don't want that excess to bond to the denture, but be sure and don't get any inside, of course, where you are looking to bond the insert to the prosthesis. So what's really cool is Zest has actually a toolkit. Look, y'all are young. You're going to be in practice for a long time. The key to doing really proper dentistry, one of many keys, of course, but is to have the right instrumentation. And folks, it's a minimal investment, but it's going to save you chair time. And that's the thing that you have control over, really, is chair time, to increase your production, which is going to increase your financial, your ROI on cases. But they do make some very nice tooling, a small kit that they have that this really shaped burr like this creates threads into the retention area that you created, the recessed area. And because what we're doing here is you're creating a mechanical retention for for the material that you're going to be injecting to lute or bond the attachment housing to the prosthesis. So you're going to have both a chemical bond because of the material bonding to the acrylic, and you're going to have a mechanical bond. You want both. Very important that you create both a mechanical bond and chemical bond. Please make a note of that if you're writing things down. When you do this, if you don't have that burr, maybe you're going to do one later today, let's say, just make sure that you're going to open this up enough so that when the housing is seated onto the abutment, try the denture in again. What you're making sure you want to have 1 to 2 millimeters a gap around this between that housing itself and the denture. You want that space to have enough thickness of the material you're going to be injecting to bond or to lute that housing to that prosthetic to the denture. Without that, it's going to be frail and fragile and will not last long, and the patient's going to be back very shortly for you to fix that. So get it right the first time, make enough room. Something that can help you sometimes to figure that out is you can put a little bit of wax inside the denture before you seat it down over this housing, then take it out, and then with a probe, you can take and push it into that wax that's in the top of that denture base and see if that's 1 millimeter of wax and probe the wall of it. You can kind of get an idea for how much gap you have. When in doubt, create a little bit more because less is going to be a bigger problem than having more space. So please keep that in mind. Now that we've created our receptacle areas, then like I mentioned already, you want to put a little Vaseline around those other areas. Again, not inside. Very important. I don't think people understand the value of these spacer rings. They come with the abutments. I would suggest that you order an extra pack of them. We're talking about just small dollars for this. You want extras because you definitely want to have these rings. It's not just one ring per abutment. You need to have a ring underneath that housing, between the housing here and the gingival tissue. You want nothing to see but rings. So sometimes you might need to put 2 or 3 rings based on the cuff height that you have. So if you're going with a 2 millimeter cuff height, you're probably going to automatically need two of these spacer rings. If you went with a 3 millimeter cuff height, okay, just do the math. You're going to need 3 of them, and you may need 4 because the rings are just under about 1 millimeter. So, just as a tip, make a note of that as well. Have extra spacer rings in hand. You have to use them, or you're going to be you're going to not have any fun trying to figure out which abutment locked that denture in because you can't see, and you're literally going to be cutting windows into the denture. And I've only done it twice in my 40-some year career, and 30 years in implants. So that's 2 times too many. So trust me on that. Here's another tip for you. Now that you've got your recessed area determined, the next thing you want to do is you want to create what we call a vent. And that's for the excess material to express out through this little vent hole versus going through the integular side and where hopefully you did remember to put the little Vaseline there so it doesn't bond to it. But take about a number 8 round burr. Smaller than that, because of the viscosity of the material, may not be real helpful for you. You don't want to create like a garden hose effect where it's a small hole. You want a big enough hole so that the material is going to come out freely through that area. And the key to this hole is right here. You want that vent hole to be located at the top of the abutment. So if this was the top of the abutment, you want to see that vent somewhere around the top of that abutment inside the denture. You don't want it down here because what's going to happen is when you have the material loaded into the denture and now you're seating the denture, that air is going to need to escape out, and you want the excess material, as you see here, to express out here. That way, you're getting that hydraulics, if you will, and it's flowing the material in around all those mechanical retention you created in the prosthesis. And when I show you some more pictures coming up, the housing, the outside of that housing has undercuts in it, so that's how you're getting that mechanical retention. So These things may not seem real important, but they really are. There's a purpose for all this. So they're multi-purpose. One, it helps you from having a lot of flash to have to clean up. Secondly, it really helps to ensure a good stream of that material under light hydraulic pressure to form and fill in all those areas to help eliminate any voids. It's not a bad idea to put a little Vaseline out on the outside here too. So that little piece right there, you can literally just flick that off or hit it with a burr real quickly and a rubber wheel and you're good to go. So another tip here. So now we're getting to get ready to, we've got our vent hole created. We got our spacers in place. Some situations, it might be very beneficial to use a rubber dam. You don't need one much larger than about the size of a nickel or a quarter, but that's up to you. Make the judgment on that. No harm, no foul to use one. Even with the spacer rings there, it's still not a bad idea. But the key is when you're filling up these recessed areas, don't fill it full. Keep in mind, you have that huge housing that's going in there, and all that material is going to go somewhere. So if you get this area filled to about 2/3 full, that's going to be plenty of material. You're still going to get excess. Look at this here on the right side here, it's a little bit blurry. But this was what you see right here, and that's kind of just about full. Quite honestly, I think we got lucky because it was just about the right amount of material here. So don't fill that completely full, but 2/3. You'd rather have some excess than not have enough because you don't want to come out and have it break off because you didn't have enough material. You got to find that little happy medium there. Then you're going to light cure that in the mouth. We find that it's best to have the patient closed. Cotton rolls, just have them closed down on cotton roll, not biting, just closed in a position because you don't want to process these inserts in function in a closed vertical functional position under pressure because we want to have some movement here. And if you close it all the way down so that you've taken up any of that space potentially there, it's going to be a little bit of a problem. So we want to have a cotton roll closed down and then light cure. You're going to use a material. Zest chairside is the material that most people use. There's other materials available, but you're going to want to use a dual cure material. And the reason for that is you want dual cure so you can hit it with the light right away to set it right away. And then dual cure because if your light isn't strong enough, maybe the acrylic is thicker in some areas, and the light doesn't penetrate, you still have the self-curing polymerization of that material to go hard. Now, here's the other thing. Don't rush it. Just because you hit the light cure, you did your 30 seconds on the lingual, 30 seconds on the buccal, that you should just go ahead and lift it up. Let that self-cure do its job, which is about maybe another 2 minutes. Just because the worst thing, not the worst, but another bad thing that can happen is you go to take it off and you take it out and it's just stringy acrylic because it's not cured yet. Then you just got to take it all apart. Some of it's cured. It's just, a lot of little tricks and pearls to this. But again, watch those videos on YouTube. Dr. Shear is going to share all that with you. It's very cool that he's done all that. Now, when it's set up, you remove it from the mouth with a small little tip, applicator tip that is available. What comes with the Zest chairside material. You just want to backfill any voids around the housing in between the housing and denture. You don't want any area for food to get packed in there. So you would have used what's called the processing insert, which are the black ones when you process that denture. And the reason that you want to use the black insert, I mentioned about closing down. This doesn't have any movement or any give, so that does help to prevent that denture from moving. But you don't want a patient biting down, even with this in place, because there's still a propensity to put that denture in the wrong position. So we want it with these black processing rings in the inserts when you're seating it with the onto the abutments and then seat the denture with the luting material. That way, everything's in a proper position once it is cured and processed. Then the one end of the tool is going to be used for for placing the insert, and it's going to be the end that's got a little hollow end in it like this. And the insert, by the way, when you do the inserts, always start with the least retentive insert. There's three inserts available. 3 pounds, I think it's 3 pounds, 5 pounds. I want to say 7 pounds. But you'll get there. They have a chart that will come with the when you get their inserts. But use the least retentive at first when you insert them into the denture. The reason I say that is for majority of the times that's going to be plenty for the patient. And quite honestly, to give them the good retention, wow, that's really great. And they pop it off. They really like it. If you go and they go, well, is that all I'm going to get? Oh, no. Now you could go to the medium and these would take 30 seconds if even that to remove. Um, then you can place the medium one in and try that. And usually for sure that should be enough. But you be careful, and I caution you to use the maximum retention because based on the patients, if they're arthritic, sometimes they can't get it out. So you got to find that balance of giving them stability for function and the ability to remove for home care. Very important that they're taking this out really after every meal and just rinse and make sure there's no debris that gets anywhere that can cause friction or wear. All right, so that was doing a chairside conversion. Pretty straightforward. Not rocket science to do that. Some real key tips and pearls to remember. Let's say now that patient's denture is not salvageable. Let's say that the teeth are broken down. They're not happy with it. They've had it for 20 years, and they want a new denture. So you got two ways to take an impression. Actually, there's going to be three ways. I'm going to show you digital on the next in a few slides coming up. You're going to either be able to take a PVS analog impression at implant level, or you're going to take it at abutment level. And we'll take a look at both of them. And once again, cannot, really emphasize enough. Go to YouTube and check these out. I've learned so much, not only from Dr. Shear, but other clinicians, other technicians posting there's a lot of videos on there. It's really cool that our profession is really about sharing information. And, don't ask, you don't get, my friends. So if you wanted something, ask for it. So here, what it looks like if you're going to use implant level impressions, you're removing those healing caps that were on there from the day of surgery. This could be either the day of surgery or uncovering, but it came from the surgical practice to you to begin the restoration, meaning the implants are integrated, tissues healed. You remove these healing abutments, and then you place here on the left this is actually an open tray impression coping. They are the most accurate. You could use closed tray as well. Again, you can get the pros and cons from some people. I think, patients deserve the most accurate here. So these are open trays, impression, very, very accurate. And I think that's really the best way to go. Let's give our patients the best. And you all are going to be practice for a long time. You're going to be building your reputation on what you're delivering for your patients, how you're treating your patients. So start off right in the very beginning. Don't cut corners, and you'll thank me down the road when you're gray like I am and say, "I remember that Jeff Carlson said don't cut corners." Then what's really neat if you say you go ahead and you put the abutments on. Again, different ways of doing things also can be different costs to you. Your lab fees can vary, componentry fees will vary. But what you're seeing here, these are the abutment impression caps that Locator has. I don't call them this, but Jane Hartner, who is a wonderful person at one of our labs at Twin City Dental Labs for been in business about as long as I have, does a lot of these cases and really likes this technique. She calls them upside down champagne glasses. So they snap on top of the locator abutments, and you can't get them on wrong. They just snap on, and then you take the impression. You can see the base of that, if you will. The base of the wine glass would be, or the champagne glass, would be captured, locked into the impression material. So Chair side, then um, you would place the locator abutments, you place the locator impression caps, and then you inject material around that, then load up the tray and seat the tray. When it comes out of the mouth, then you can do this with the analogs, or the lab will have the analogs. Someone will have the analogs. I think it's good for you to have the analogs, and that way you can pop the analog into the insert, make sure you feel it snap into place. That way you know that everything is right and you still got the patient there if there was a problem. And then there's your working model. And the working model is going to look the same regardless of if you did an open tray or a closed tray. It's just the accuracy of it. So this is what they came out with new is a digital, it's a scanning abutment. Um, and it just snaps on to the locator abutment and you do your iOS scan. It is really slick. And here's an actual image I took off a laptop of the scan, what it looks like being scanned. This is what you see the laboratory, what the laboratory receives. Then the bottom image is what the laboratory has done in the planning stages in their exocad software, where they've designed, they see where the abutments are, they put the teeth, the flange. So this happened to be a case we were doing for a fixed locator. That's why you see six of them. You're doing a locator, two implant locator, just remove those two posteriors on each side. But you get the idea. So we're in the digital world, but be aware that everything's still not digital yet. They'll say it is, but digital technology is still it's still growing and improving. Analog, and a lot of times you still need to take some PVS impressions to capture the tissue. We still have a challenge capturing tissue. We don't have time to get into that today. But if you email me and ask me for PDFs of other webinars, I have a lot of information you can watch on your own time. I have table of contents. You can fast forward to different topics. So please take advantage of that. All right, I'm going to wrap this up now. I'm going to share with you. Um, let's quickly recap. We did, patient comes in with existing denture. They're okay with that. So they just wanted to have more stability. So you're going to get two implants placed, uh, convert that denture chairside, or you don't have to do it chairside. You could take those impression caps and do that and have the lab, process the dent, do the models, process the denture, but the patient's going to be without their denture. It is more accurate to lute attachments in the mouth. So you don't let fear get in your way. Because that is the most accurate way to do it. Just follow some real good fundamental steps and you'll be just fine. So we went from doing that chair side of existing denture. We talked about what if you need to make a new denture, open tray, closed tray, implant level, or abutment level, and then move forward that way. Then we covered about a digital protocol. So now let's say that the patient wants to go to something fixed. This could be from the very beginning. They say, hey, I'm tired of my denture. I want to do fixed. I've looked into this all on X, all on 4, and $25,000, $30,000. I just don't, I can't afford that. Well, the great news is there's an option here that's kind of right between the price range for patients. It's about half the cost of the all on X fixed screwable, if you will, a scrutainable is another phrase some people will use. But on the all on 4, all on 5, all on 6, which that's why they call it all on X, because it may not all be just all on 4. So let's take a quick look at this. This is taking, or maybe that patient had a two implant overdenture, and 5 years go by and they got a little more money now, and they say, Doc, I would love to get something now that doesn't even come in and out of my mouth. Well, you can add 2 more implants and do what we're going to show here. And you still could use that existing denture. How cool is that? And use the existing 2 abutments that they had. So what's different here, so the locator fix, the housing is different. It's designed different. It has more aggressive undercuts because it's going to take a little more strength here. There's going to be more forces trying to pull it apart, if you will. The insert is entirely different. It's a different material, a different design. But the good news is it's the same abutment. And this is the priciest part of this componentry is this abutment. So if a patient has existing abutments and they are not worn, that still has that gold nitride coating on them, you can use these and retrofit to a locator fixed. And if they had four locators of the standard locators, you can make it into a fix by doing nothing more than changing the inserts chairside. And then you have to, of course, cut the flanges down because it's fixed. You need to be able to get in there for hygiene for home care. Um, so here's what you're seeing is different. The height is the same, how much inner arch space they need, but you see there's a simulation of movement here. That's what on a standard locator, like say with two implants, that metal housing actually is kind of rotating around that insert like this. That's where they're getting that movement. Whereas with the locator fixed, there is no movement at all, hence the word fixed. As you see, 9 to 11 millimeters is still the same for doing this. So in a snapshot here, the top is your locator removable. The bottom is going to be the locator fixed. Same abutment, same processing insert, and the pickup method is the same in the mouth. Okay. What's changing is going to be that housing, as I already mentioned. The inserts are going to be different. And then what's going to be different is the appliance or the prosthesis itself. When you're doing the standard locator, you're going to maintain your flanges because you still need that for stability. But when you go to the fix, you're going to have to cut the flanges off, and some areas you're going to need on the integral side, you'll need to fill that in so you don't have a concavity because they can't get floss into that concavity, and that's going to be a food trap. So you don't want a gap inside. If this is the crest of the ridge and the denture has this gap in there, you don't want that gap. So you might need to do a little reline, if you will, to close that space up. Very minor adjustment. And they make it very simple with this technique, but you need to follow this very specific instructions. If you're doing a four implant fixed locator fixed, you're going to use four inserts and you're going to use four of the green inserts. Very specific. When you're going to do five implants, you're going to use two of the blue inserts in between the three green ones. Very specific. They have a lot of literature on this, so when you order, you'll have this, but follow this guideline. Don't violate these principles. They came up with this for a reason. So here you're looking at six implants. Once again, we're using just two blues. If you put more blues on, it's going to be very difficult getting this out. So talking about getting it out, this is the tooling that you'll need to have when you start doing the locator fixed. It's going to be this little trigger here, gun, and it has two attachments. These are the tools to tighten it with. And then this is a driver similar to that locator tool I showed you, but it's beefed up more because when you go to place these inserts into the housings and the denture, you need something a larger handle to put some more pressure on. So that's why you have this new tool. Again, you need the instrumentation to be doing these. Now, this is how you're going to seat that locator fix. So you have it, all the attachments have been processed. You cut the flange, it's polished, it's ready to be delivered. You're going to place this tip on the end that has a soft, hard pad on it, and that gets placed into your tool and tightened up with your tool with a little ancillary tool. Then you're going to seat that, just set that over each implant site, set it over the most posterior implant site, and you just pull that trigger together and it snaps it down into place. You move to the next one over the next implant site, snap it again, squeeze that trigger, and go around each implant site, and that locks that prosthesis. So 4 times minimum, you're going to go click, snap, click, snap, click, snap. And the patient cannot remove that. You cannot remove that without this tool. So now you're going to do is you remove that denture for hygiene. You, instead of using this little hook with the pad on it, you'll use this wire loop that gets inserted into the end of the driver, and you lasso that over the distal extension of the prosthesis, and you drag it up until you hit the distal of that first implant. So you've lassoed it over, you pull forward, and then you just take the slack out of it and you pull that trigger. And this time, when you pull the trigger, it pops that denture up off of that, it pops that prosthesis off of that one locator abutment. Then you just keep it lassoed in there and just drag it forward to the next implant site, take the slack out, pull the trigger, pops it up again, drag it around, and it's just pop, 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 and it pops it up. It's probably a 10-second, 15-second to remove it. Now the hygienist can do her, inspect the abutments, can do some cleaning on the prosthesis if need be. But you've done a great service for the patient with this prosthesis. So look that up online, get some more information. Thank you so much, everyone. Really appreciate you all. I wish you all the best on your journey.